Thank you, Dr. Maharotra and Dr. Jayesh, for a wonderful opportunity to talk on complication avoidance in MIS TLIF. We all know Dr. Foley came up with tubular retractor system in 1997. Initially, they were using endoscope, and then they migrated to surgical microscope. And in 2005, they came up with the technique of MIS TLIF. Before we discuss on complications of MIS TLIF, what do we mean by complication? Do we mean only the mishaps that can happen during surgery or immediate perioperative? The answer is no. We have to look at 90 days morbidity as well as mortality for patient in any surgical intervention. We have to look for complications like delirium, postoperative retentions, ELIAS, etc. also into our armamentarium and try to prevent and avoid those complications. Keeping this thing in mind, my talk is divided into four groups. First, we will try to optimize our patient following an ERAS protocol. We will quickly take you through some of the technical tips based on my experience for preventing mishaps during surgery. We'll talk about learning curve, and finally we will compare open TLIF with MIS TLIF and what is the recent literature say about. So for preoperative optimization, the enhanced recovery protocol has been published very recently with a consensus statement in 2021. They have included all the parameters what we are getting confused day in and day out for our patient. They have numbered it. I will quickly take you through each and every of the parameters. Preoperative education and counseling is very important to improve outcome. Prehabilitation has no much significant role in RAS protocol. Perioperative nutritional supplementation is very important. Make sure that your patient is higher albumin level than 3.5 microgram per deciliter. 3 to 4 weeks before, ask your patient to stop smoking, and 5 to 6 weeks before, ask your patient to stop alcohol. You can give clear fluid to your patient up to 2 hours before your surgery in NPO protocol. Avoid solid food for up to 6 hours. Anemia needs to be managed before you take your patient for surgery. Antimicrobial prophylaxis, we all know that broad spectrum third generation cephalosporin should be infused at least 30 to 45 minutes before you start your surgery. Standard anesthetic protocol needs to be followed. Hypothermia prevention is very important. Use thermers. Surgical technique has to be crisp to avoid complications. At the end of the procedure, try to infiltrate your patient with either epidural or intrathecal analgesia. Also use local infiltration to avoid pain in your patient postoperatively. Fluid management is very important when you are doing a long level surgeries. For 1 and 2 levels surgeries, it is not of much important. Early postoperative oral nutrition needs to be started as soon as possible. Generally, it is recommended within 2 hours of your general anesthesia, and that will prevent ELIAS in your patient. Avoid putting catheter as far as possible. For 1 and 2 level patients, we don't generally put catheter, and more than that, we try to remove catheter within hours of surgery. What we do is we ask our patient to empty the bladder before we take the patient inside the OT, and after the surgery is over, before patient is shifted to recovery, we put a K90 and empty the bladder again, and next day patient is, or same day patient is mobilized. Postoperative analgesia is very important. Postoperative management of drain. ERAS protocol doesn't recommend that you should be using drain. There is no clinical consequences of not putting a drain in your patient. Generally, spine surgery where patient is going to be mobilized quickly, there is no role of chemoprophylaxis as far as thromboembolism is recommended, because as such the rate of pulmonary embolism or DVT is much less in a patient. So you have to reserve the chemoprophylaxis only for those patients who are at high risk, like long surgeries, deformity surgeries, patient who have morbidity for to prevent early mobilization, and those kind of the patient you should use a low molecular weight before it. As I said, try to mobilize your patient as early as possible and continuously try to audit your patient. So this was all about the ERAS protocol and preoperative optimization of your patient. What about postoperative antibiotic? We always are confused how long we should use antibiotic. So very recently in 2021, JBJS American edition, they've come up with around 4,000 patients studied, and they have included all our biases like higher BMI, comorbidity in our patient, MIS or open surgery, whether instrumentation, number of level fused. They had incorporated average number of fusion was around 3 levels. Approach, estimated blood loss, all these parameters they have included, where whether this postoperative antibiotic is helpful or not. Now this group is very heterogeneous. So what they did was they did a propensity match scoring, and then finally they had included in each group around 1162 group, and they compared both the group with no postoperative antibiotic and postoperative antibiotic, and they could not find any difference whether you give postoperative antibiotic to your patient or not. The infection rate was same whether you have given postoperative antibiotic or you have not given postoperative antibiotic. They have studied all these strains, GPCs and GNBs both, and they could not find any difference whether you have given preoperative or postoperative. Also, whether you have given postoperative antibiotic. Now they did a regression analysis, and they could find that only male sex, higher BMI, and higher estimated blood loss were strongly correlating with postoperative infection, not the postoperative antibiotic. So, in conclusion, whether you give postoperative antibiotic to your patient or not, there is no bearing on your postoperative infection. Let us quickly take you through some of the tips what I feel that can prevent surgical mishaps. You know that there are different kinds of tubes. Before you begin your surgery, make sure that you have appropriate size of the tube, because sometimes it may so happen that we don't tend to procure all the sizes, and when you have a deep patient, you are not having those kind of a tube, and an MIS surgery cannot be performed. The next question always comes is, should I use a fixed diameter or an expandable tube? So generally what we recommend that initial learning curve, try to use an expandable tube, but as you get proficient in your technique, try to use a fixed diameter tubes, because it is much easier to manipulate, much easier to handle while doing an MIS TLIF. Use bayoneted equipment so it doesn't come in your way. I never use a guide wire. I always use my finger to dissect and feel the landmark, and over my finger first dilator goes and then the subsequent dilator. Level, sometimes you may miss level, because specifically in a patient which are very fatty or patient with hyperlordotic spine, a subtle movement of the tube can lead to a subjacent or a suprajacent level of your fusion, and if you are not very careful, you may end up operating on a wrong level. So before you begin your capsulotomy on the side where you are operating, make sure to confirm your level. Always finish your bony work before you remove ligamentum flavum, because ligamentum flavum would protect your nervous structure and dura. The commonest complication during a learning curve or when compared to open is the dural injury. So if you want to avoid dural injury, try to finish all your bony work as early as possible before you remove your flavum. Plus, that gives a lot of bone. You may have to maneuver your tube also to get autologous bone graft in your patient. Always decompress foramen before you start retracting your nerve root, because otherwise your patient may end up having a neuropraxia or a battered root syndrome. Avoid using sharp instruments, in your patient, because sharp instrument may damage and tear. So I generally use a 8mm sharp disc spreader, and then subsequently I use a blunt distractor in an incremental size, so that my end plate is preserved or protected as much as it can. I always try to remove finally a lip of annulus which is hanging from the posterior lip, so that it doesn't entangle into my cage and my cage insertion becomes much easier. I've seen that when you have not removed this, it requires quite a lot of force to put the cage inside. When you are trying to put a larger size of cage which are not going inside easily, try to do a superior pedicle drilling or an isthmus drilling to create a space so that a larger size of cage can be inserted. Make sure that before entering into this space with your cage, your tube's long axis is parallel to the long axis of the disc. Because if it is not, or if it is at slightly an angle to the long axis of the disc, what can happen that while inserting the cage, your cage will damage the end plate of inferior vertebra or a superior vertebra, and sometimes it may lead to this kind of a catastrophe, where this is one of our patients where we forgot to check this, and the cage went directly inside the L5 vertebral body, and we had to convert it to open, remove the cage and put it on the next side. Simply docile looking minimal invasive spine surgery. We had to put the patient on bed rest for 3 to 4 weeks time, so that this segment heals. Specifically, when you are doing an over-the-top decompression, make sure that you have horizontalized your table before you start inserting the cage, because otherwise what may happen, if your table is still tilted, your cage will go quite on the opposite side, sometimes abrading a dura or giving attraction to your nerve root, and your patient may have a neuropraxic injury or again a battered root syndrome. Use appropriate size of cage so that your cage back out doesn't happen. This kind of cage placement is a big no-no. try to put your cage as anterior as possible so that back out chances are much less, as well as anteriorly placed cage gives much better lordosis. This is one of our patient which was having a fixed spondylolisthesis, and we traditionally, this was around 6 years back, we operated this patient, and we were traditionally doing a ipsilateral side of facetectomy and cage insertion. So without releasing the opposite side of facet, we went on expanding the disc space, and finally we could insert 14 cage. We were quite happy. This was a post-op X-ray, looks okay, and this was the post-op X-ray after 1 month. You can see that what happened was that cage actually went inside the end plate to a significant sinking of cage, because we had already damaged the end plate while doing an overzealous destruction of the space without doing adequate release. So we learned from our mistake, and what we did in next fixed patient, we did a bilateral facetectomy. We did a complete posterior annular release, not only in the center but also on the both the side of lateral aspect of annular, and finally we could achieve a very good disc height. Not only that, we could achieve very good lumbar segmental lordosis as well. When we talk about segmental lordosis, always make sure that you have achieved a proper segmental lordosis. One tip is try to distract slightly more than the intended cage size, and then put that cage which is slightly smaller than the distraction amount. While putting cage, put screw on the opposite side, which will keep that distraction in space. Then you hammer your cage inside and achieve a good posterior compression to achieve a segmental lordosis. Initial our cases, few of the cases we find that there was significant posterior bone growth, and that some of the patients started coming back after say about 9 months, 10 months with a radiculopathy because of this extra bone growth. And we reviewed our cases, and we found that in my previous cases, what I used to do to put cage inside the posterior lip of the end plate, I used to osteostomize so that cage insertion becomes much easier, and probably that raw area of bone was leading to new bone formation. So I started, amending that kind of a surgical technique, and I started relying more on posterior distraction and then putting the cage inside. But in some of the cases where you have to do that osteotomy of posterior lip, make sure that you cover those raw area with bone wax so that new bone formation doesn't happen. Now, this is how I started my MIS journey. First, I used to do an open procedure, place a tube and do my surgeries. Learning curve, I would want to quote 2 papers, one by Dr. Alok Sharan, where they studied their first 55 cases, and they could find that operative time, length of stay were significantly less after their first 21 cases. There was no significant difference when compared with first 23 and last 32 patients in terms of blood loss, ODI, VAS for back or leg pain. Even complication rate remained quite steady. Another study by Dr. Kern Singh, they also studied all these parameters like surgical time, duration of anesthesia, EVLs, and postoperative outcome. They compared first 33 cases and another 32 cases. If you see this graph, the blood loss, surgical time, and requirement of fluid decreased as your number improved. So they concluded that first 33 patients took more time, more anesthesia, and required better fluid management than the subsequent 33 cases. Now, finally, when I compare this MIS TLIF, I would want to quote a 2017 trial by none other than Dr. Kevin Foley and Momanini group, and they had studied extensively 100 patients in both the group, MIS TLIF as well as open TLIF, and they found that statistically significant was only one parameter, and that was estimated blood loss. Length of the stay, they concluded that it makes difference only for half day. There was no other difference in any of the parameters like readmissions, resurgeries, or complication profiles. As the VAS and back VAS for leg and back remained same for both the group. Even when they did a subgroup analysis for patient with lumbar canal stenosis and the spondylolisthesis, leg pain and back pain remained same in both the group. Early return to work was also not significant with MIS, and they finally concluded that regardless of approach, it is the lumbar interbody fusion which was associated with significant and sustained improvement in all measured health domains. MIS is associated with reduced intraoperative blood loss for both 1 and 2 level lumbar fusion, and a moderate reduction in mean length of hospital stay for 1 level lumbar fusion, not even for 2 level lumbar fusion. Compared with open, MIS was not associated with any improved perioperative safety measures or 12-month patient reported outcome. So they concluded that our findings do not necessarily signify MIS procedures, when performed in an optimal way, are equivalent to open techniques. Rather, they reflect the real world experience of how spine surgeons are currently using MIS tools with resulting benefits that are more modest than expected. In summary, MIS TLIF is a beautiful procedure. There is a learning curve of around 25 to 30 patients. Once you master that, MIS is a piece of cake and you would enjoy operating on your patient. Complication profile is more or less similar to open and you can safely do this procedure. Thank you so much.